Hi, everyone. Welcome to another episode of Ace Strategy and Consult podcast, known as Ace Podcast. I'm so happy to have you here again. We're going to be discussing an amazing topic, a continuation of what we discussed some time ago. I hope you did watch that episode. My name is Dr. Victory Ekman, and I'm going to be the host today. And with me today, I have two amazing guests that we had last time. So we're going to be continuing the discussion. On my right, I have Afiz Olajure, the managing partner and CEO at Ace Strategy and Consult. It's so nice to have you here, Afiz.
Yeah, thanks, Victory. Always a pleasure to connect with you.
Always a pleasure as well. And on my left, I have Toluwanimi Adewale. The last time I said she comes in with a vibe. She really does. It's so nice to have you here, Nimi.
It's so nice to be here.
Yeah, so Nimi is our senior engagement manager at ACE and also leads the maternal health portfolio here at ACE. So, in the last episode, we talked about maternal mortality, the silent crisis. We identified some of the problems, and we did not go in depth into some solutions on how to solve this problem, but we talked deeply about the problems. Today, we are going to be talking about solutions. We're going to be talking about turning the tide on maternal mortality. But before we go into that, I would like to just identify what are the problems that we talked about the last time. What are some things we brought out? Afiz?
Yeah, thanks, Victory. I think the last time we emphasized more on the problems because we feel before diving into the solution, if we are actually planning to co-create a solution that everyone could participate in, we need to spend some time to actually detail out what the problems are so that it could be an all-hand-on-deck kind of approach. And some of the things we spoke and we emphasized during the last podcast, one is around access. And access from the lens of when we finally get people to go to the health facility to access care, and that's the mothers. How are we ensuring that we have the commodities to attend to them at the facility? We have some question around the coverage that they have. Out-of-pocket expenditure is not a joke. People can't even afford some of the basic commodities that they need to save their life. Example, we have the oxytocin, we have the tranexamic acid, and all other commodities. So all of this, and knowing that most of these things are not even covered in the package that should be used for the healthcare, that people should have access to be covered by the health insurance agencies at state and national level. So all of these problems further worsen and slow us down from moving from the position where we are to where we desire a world where every woman do not have to lose their life while giving life to another. So yeah, those are some of the problems that we discussed at the last time.
Yeah, thank you, Afiz. I'm remembering a couple of the things that we discussed. Nimi, do you remember anything extra?
Yeah, I think it was, we had broken it down into looking at it from a system-wide lens, right? Being able to say what are the key things or the key pillars that will be required to ensure that at the end of the day, the end user, which is the woman that's faced with those problems, that she's able to access care, she's able to afford it. Like you said, commodities are available. And we also looked at it from the government lens, and we had mentioned a few things, even though we had focused on problems. I mentioned a few solutions that the government also kickstarted or put in place, which is MAMI. I think we also touched a little bit on that as well. But yeah, those are the things that I remember very clearly in terms of the issues identified and potential solutions to addressing them.
Yeah, so I did remember that we broke it down into several systems, different systems, and we also broke it down into, the community level problems, exactly. And then, at the different cadres at facility level. So I'm just going to write on, you said some solutions have already started being enacted, and we are here to talk about the solutions. So I'm going to hand over the first question to you. What are some solutions that we can look to? I want you to bear in mind our context, the Nigerian context, and the fact that we have different cadres and different levels of care and different people that have different levels of access to care. And maybe looking at a community lens, or I don't want to stifle you. Tell me about what you would think would help solve some of these problems. And overview, yes.
Okay, so I think I will start with the fact that several interventions are in play. I think that is one key thing to understand, that people have risen up to, if it's to either invent something new or to make something that was existing better in trying to solve different pockets of the issues, right? And like I mentioned earlier, the government too has also kickstarted an intervention, if you like to say, it's more like an approach, MAMI, right, which is supposed to also address the different points or the different issues at the different pillars, right? But I'll take it from in terms of the community lens, like you had mentioned, and not because I don't want to not flog, but I don't want to address the facility issues, is that the government is already doing work there now. So I want to talk about how closely the solutions that would help us to target what's happening at the community level. Now, my understanding of the issues there or the systems that work there is that whether you like it or not, you are very attached to your community. Your first point of contact is at the community level, whether we like it or not. It's just the truth. Even myself as an example, before I think about going to university, I'll think about what's going on with me. Let me meet somebody that's a fellow doctor in my community, or meet somebody a pharmacist. Yes, you understand, within that level exactly. So I realized that that's where we need to pay a little bit more of attention to, right? In the current system that we are, like you said, in the context, because if you look at it, I've just talked about from an urban lens. In the rural lens, is even deeper. The community is their first point of contact. So in my head, it's how do we target that aspect and work with it? And these are a few things. So we have what we call community health extension workers, junior community health extension workers. We have, I know then in the polo we had voluntary community mobilizers. We've had what we call CHIPS agents. These are people that have first point of contact with women. Of course, lest I forget TBAs, right? We are very big on discouraging home-based delivery, but how do we empower the TBAs to serve as referral agents for the woman, knowing that that's usually their first point of contact? How do we leverage the community structures to deliver services, right, in such a way that the woman already is receiving some level of care before she gets to the facility? Now, I know that most of the time when I talk about community-based systems to address service delivery challenges in terms of maternal health, the first problem that pops into my head is, would that be, for lack of better, would that be used incorrectly in terms of, would these people begin to abuse? Would they begin to abuse the training that has been given to them, or the privilege, because of task shifting, task sharing policy, right? And ensure that they're not abusing that and then beginning to have deliveries at home. Right, so we need to now think about how do we ensure that the line between community and facility is very clear. That as we are building community structures to deliver services and to ensure that the woman is fine, we're also ensuring that the facility is also has the capacity to be able to, provide care, and then the linkage between the community actors and the facility is very clearly stated, very clearly. What's the word? Written. Maybe not the word written, but at least it's working. You understand what I'm trying to say? So for me, the best answer to your question is, from the community lens, I would say let's strengthen that. But then as we are doing that, because if you do something too much, you forget that there are problems that can exist because of it. We must ensure that we are thinking about how to bridge those gaps and make sure that we're not having more home deliveries when we are trying to reduce that and improve facility deliveries, right? So that's it from my end. From the facility end, I'm not trying to take your hosting.
Before you go on to the facility end, I want to ask Afi some questions on the community lens before we go into the facility lens. But before that, don't forget to like, share, subscribe, comment. We want to hear your thoughts. We want to know if you have questions, if you have comments, if you have suggestions, please share them. So Afiz, Nimi has talked about service delivery. So at the community level, I would like to think of it like there is a service delivery aspect, but there is also a demand generation aspect. And one of the problems we identified in the last time is that there are so many social and community norms that stop our women from giving birth. So looking at a solution from that lens, what would you prefer? And this is at any level, whether you're talking to practitioners, you're talking to the government, you're talking to international organizations, right? What would you prefer with regards to demand generation for facility birth and skilled birth attendants in our communities?
Yeah, thanks, Victory. I think that's quite interesting. And the very delectable Nimi has already mentioned a lot of brilliant gem in that light. I think for once, and as a country, we need to start treating maternal mortality as the emergency that it is.
Yes.
I honestly think we treat it, I always use the word, we are living a fake life. We respond to it like it's not a problem, even though it's one of our biggest problems.
Yeah.
And I say that because in a country that is grasping with resources, we have a lot of community level advocacy efforts. At least I know my organization at ACE do something in that light. There is the edutainment strategy where you are looking to use comic activity to drive demand for other activities like polio, like azithromycin administration, and a lot of other programs. I'm wondering where it will be declared like a national emergency. I was quite impressed when the country changed NHIS to NHIA. Meaning it's now an authority and everyone should subscribe. It's no longer elective. But I'm looking at where we would declare a national emergency on maternal mortality, that every advocacy effort, every message, every behavioral change communication message must have an undertone of mobilizing the women to access quality health care to prevent them from dying at giving birth. Because we have a lot of those interventions. We have them going on. We have many partners doing a lot of things. But what's different is people just focus, oh, we want to do polio, we want to do nutrition, we want to do this. But I'm looking at a world where we're actually addressing this as an emergency. Because there are really no major, we don't need to innovate anything new again. What we need to do is, in the context of everything we have in the place that are looking to address and fix other problems, let's make sure maternal newborn health is a message that must go. Nimi already made very brilliant points around how we need to, on maternal newborn lens, we're already saying we need to see, there is a lot of emphasis on getting people to go to the health facility. But like the point I raised during the last time is, in being honest with ourselves, are the health facility ready
to receive all these people?
So if we know the health facility are not ready to receive all these people, I think we should then start looking at how to strengthen the community structure to attend to some basic emergencies. Because if every woman must go to the hospital for ANC, we already know as a country we can't get there yet. Because the number of pregnant women, if you look at the ratio to the number of health facilities that we have, it's not, the proportionality is faulted already. And that's why we have all of this community structure. Like my colleague mentioned, we have the VCMs that we use for immunization. Just like every other problem in the country, like security and all, you can't solve a problem without the community participation. I don't know the woman that got pregnant in a particular local government in my state yesterday, but the VCM, the voluntary community mobilizers, the JHU, the TBS, they know. And until we start involving them in our plan to play key roles, and kudos to the Federal Ministry of Health, kudos to the MPHCDA, the SWAP office, NHIA, that's now the direction everybody is moving. Because we know we cannot crash this maternal mortality if we keep excluding the community structure. Because they are the first contact of these women, and we need to equip them to be able to address to those issues and also serve as a referral linkage point between what happened at the community level and when an issue is escalated to what is required at the facility. So for me, I think that is how I'm going to tackle all of this, which is let's harmonize all our messages, declare this as an emergency, live the real life and live the fake life. Of thinking it's not a problem. Like it's a problem, we need to solve it. And every effort, every intervention, whether it's irrespective of who is funding it, should prioritize sending just one message. And those are the messages that aim to promote activities that will help us crash this maternal mortality as quick as possible.
There's something that you said, right, which is the reality, right? Although you call it living fake life and the real life.
I like that.
And you know, as a country, most of the time I mean, even as a consultant, I'm always thinking, how do I solve the problem as one piece first, then I'll go to the next piece, then I'll go to the next piece. I think we need to move from a one-by-one approach to a double-pronged approach. Is it a two-pronged or a double-pronged? Multi-pronged approach, right? For lack of a better word. And exactly. Because as much as we are strengthening community structures, we need to make sure that the facility is also able. Like you said something, you said are the facilities ready? We need to make them ready, because there are some things that we need to flag from the community. So if we strengthen the community structures and then they are now actually flagging actual issues to the facility can't do anything, then there's a problem. And I would like to, again, like you said, kudos to the Federal Ministry of Health, kudos to MPHC, the PhD revitalization that they are doing. It's very important that as they are doing that, they are strengthening community structures, they are also building on the facility structure so that the linkage is clear. And you mentioned something to the referral linkage, and that's the linkage I was talking about between community and the facility. It needs to be strong, it needs to be clear, the message needs to be one. right? Which is you need to refer at this point. If not, you begin to see a lot of issues at the community level, community taking it. And then so I would say to your point around how do we now strengthen the community structures, the CHUs, the JCHUs, let's train them. Right. And it's what exactly are we training them on? You said something, antenatal care even at the community level. It's very possible. It's easier to gather women under the tree in a particular place and tell them go to the facility where you have these women come and educate the women on this. Then you now say, oh, as at this point, you now need to go to. So no, at the first ANC, you're telling them, oh, this is what needs to happen.
Yes.
These are the drugs you need to take. These are the tests that you need to do. They are now referring them to go and do those tests in the facility. There are a few things that I think they can do at the community level. I mean, blood pressure course. I think there was something you had mentioned. We have having a conversation.
A mobile.
Yeah, exactly.
Blood pressure.
Yeah, checking your
PCB.
Exactly. Those are things that can be done at the community level, and then you're now saying, oh, you need to now. These are the next tests you need to do. This is the facility, and I think a good thing is making sure that we are mapping these community healthcare workers to facilities and mapping them to cohorts of women.
Yeah.
Such that they know that, okay, these are the women that I'm working with. Do you understand what I'm saying? They provide the ANC, that's the counseling, the teaching bit of it. They provide the low, is it low risk drugs, or what do we call it? That low dose drugs or something that they can provide.
Like
and then they refer them to the facility. They ensure that they get to the facility. There's a feedback system, a loop from the facility, knowing that this is the JCHU or the CHU that's attached to my facility. So it's like the system will just work like that, right? And we now see that. So, because if the facility can't, then the CHU is unable to say, go to this facility.
Yeah.
Right? Or is referring it to secondary health facility that's probably farther. Do you understand what I'm saying? 100%. So, it's a multi-pronged approach. And like I said, the government is doing a good work of trying to lay those systems in place and push those systems, so that they work well and they work hand in hand. But we also need to see it as like you said, an emergency. Right, as interventions are coming, and I think in the last conversation we mentioned the emotive intervention that is a game changer. Right, and I know that the government is trying to ensure that everybody, like health facilities, know how to do it. Midwives know how to implement it. We need to consolidate on all the interventions that we have, and find a way to teach it, to train, and to ensure that these are the standards that we have now, and moving forward. So that will be it for me in terms of. That structure,
So much is going on through my head right now. I'm trying to figure out which of the questions I want to ask you people now because of time. But however, please don't forget to like, share, comment, subscribe, and tag people, So we've spoken about several things. I like to consolidate. We've spoken about the service delivery. At the community level, we've spoken about service delivery, and then we've spoken about demand generation. All right. And we've spoken about, we operationalize some ways that we can do the service delivery at the community level. And I think that this is really key because the community is our strongest unit, especially in Nigeria, and we can actually utilize that a lot. But now, this brings up another problem because we've talked about linkages. When a lady is in labor, in the middle of the night, she has been followed up by her community health worker or community health extension worker, and she knows her danger signs, she knows everything, and she realizes I'm in danger. And she's in Ikorokpai Dangidide, which is my village, by the way. And the next facility is 1 hour away. Her husband just has a bike. What happens to her? That is what the next angle I want us to solve from now. All right. How can we solve this problem? Bearing in mind that we have resources problem, we have coordination problem, we have so many problems. How can we solve this? Afiz?
Yeah, thank you so much. And yes, I will speak from multiple lenses, but I will start by saying no country has attained success on any social problem without collective efforts. When you talk about Europe, America, and all, you will see that most of the solutions are from philanthropy, private sector, and governments. The problem we have in Nigeria is that everybody expects the government to do it all. Right? And because the question around the woman is in a remote area and this, so there's a problem of access. We said it the last time where we had conversation around the need to have ambulatory service.
Yes, we did.
But why should a normal birth require an ambulatory service if we have the health facility where they should be?
Yeah. Exactly.
And I love that Nimi made that point clear that we should already be linking these women to the nearest test facility where they could get value. And now back to the first illustration I made. It's not documented in any book that delivery must be done at the government facility. No. Rather, that's why I love the private sector health alliance initiative. Rather is if government want to fix health, how can we ensure that we onboard the private facility, we onboard the community facility, and we onboard everyone within that space? Meaning, if I have money to build a health facility in my community, I can be rest assured that the government will not have any problem distributing commodity to that health facility. And because I have provided the structure and somebody is equipping it, right? That person that's had issue over the night, it's just like how they were able to achieve some success on family planning. It's until we start giving those commodities through the private sector, through the community structure, that's when you can actually achieve the success. So as long as we expect every birth to have to go through the rigor of locating government facility, we might not achieve the universal health coverage and crash this maternal mortality. I honestly think all our intervention should be planned around what happened to the private health facility that is close to that woman. If that private health facility is enrolled on a particular government program that says for every birth that is rushed to you, you already, if you provide this, you will be reimbursed for this.
Don't reject them.
Don't reject them, even if they don't have a kobo. Because we already have the structure. The problem is who is paying for it. Now, if we see it as an emergency, we are not waiting for the government to necessarily have to do, because how many health facilities can the government provide? Like there is a limit to what the government can provide for us. But people are making genuine efforts every day. Okay, and the good way is that why do we have things work well in private sector than in government system? So for me, the way I will respond to that two ways. One, let's continue to make access easy, meaning we are connecting community. I've read a lot of brilliant initiative of people connecting bridges with wood to ensure that people can always shout out to the wife of Emma Abaga. She presented that at the gatekeeper. Like the work she does is she identify a community with access problem and they use wood to make bridges to make sure people can move from where they are to where they need the service, whether market or anything. Brilliant initiative. So there's a problem of access that we need to fix. There is that. But for me, is we need to decentralize care. That everything must not happen at the government facility. I just know that any health facility that I can see a sticker in front that accredited by government near me, if I enter that health facility for emergency crisis, like maternal and newborn health, child death, and all labor. Exactly. Family planning is not. If I'm going to somewhere for family planning service, family planning is optional. You are requesting for it. It's not an emergency. You are the one going there to seek the care. Yeah. But for things that falls under emergency care, someone is having asthma, there should be that enrollment that we are doing for private sector to also be in the pool of people that can provide that care and will get the desired result.
I think as you were speaking, I was thinking about it, and that's where the NHI comes in.
Absolutely.
So you know that this facility is NHI accredited. Yes. And they show their NHI card, they know that they have access to delivery for free 100%. And to these services.
Absolutely.
The problem with that now though is how many people are covered by NHI.
So if more people are, that's where awareness comes in. The problem is the awareness. If people are aware that if you enroll under the NHI scheme, right, and you have to deliver, and it's not a government-owned facility, and your private facility is closer, and you can receive care from there, but this is what your package covers, which is the emergency care that Afiz is talking about.
Yeah.
They would go.
Yeah.
If it's closer. And it's very important that we make it clear.
I agree.
They will go. And to add to his point, which he said, the two-pronged approach, which is one, work with private facilities, use maybe the NHIA scheme to, connect women to these facilities and ensure that they receive the care that they require. The second bit you mentioned, which is ensuring access. And I think there's this thing where they do the 1 PHC per ward. My understanding of the ward is the lowest level. It's like at your settlement, sort of. And then even the settlement. So then again, is now thinking about it, should it be 1 PHC per ward or should it be 1 PHC per the number of settlements? Because I've been to different
what you try to do is, because some wards are bigger.
That's what I'm saying. That
but
instead of
what you're trying to do is 1 PHC per ward. There is the PHC, there is the health clinic,
The health
there
post.
is health post.
Yeah.
So it's just that at least one, and those can
No,
take
but that can be hit. That's my point. So
Yeah.
if this the number of settlements is larger, it should be 2 PHCs.
But even when you go to those wards, you see a lot of private facilities.
So that's maybe it's looking at it from both ends,
Exactly
like
my
you said.
point.
But we just need to ensure that they also have the 2 PHCs, the 2 PHCs that is required, and they also have private. So if they look at it that way, and you see that there's 1 PHC and there's 1 private facility, then that's those settlements or what are covered. So I'm thinking about from the lens of not necessarily government owned, but facilities that can actually provide the
Trust
service.
has been broken, like I used to say. If people are confident, if people get confident that if they are enrolled on health insurance or any of these things, they are guaranteed of the quality of service they will get. Trust me, they will enroll.
Exactly.
The reason why we use all our life savings to buy data is because we are sure we'll get value. I know some service provider that we know the money we are paying is ridiculous, but we are getting value.
Yeah, true.
There are some cable TV network that are very expensive. They keep increasing their tariff, but we have to keep subscribing because they give us access to everything we want to watch. So for me, is we need to build people's trust, and the trust is from different lenses. Me as a private health facility need to know that if I take this bet, it's not going to be a problem for me to recoup because I use my money. I'll get my money back.
Yeah.
The philanthropy need to know that if I build an health facility in my community, getting health workers to work there will not be a problem. I've tried to do something like that. I know the number of letter and code they're asking me to write. And it will frustrate you that, like, I'm trying to contribute to the community. Why do I need to go through this rigor? It will be ridiculous that some people might even ask you, they'll just create needless bureaucracy.
Yeah.
And it's make you wonder that, are we actually addressing an emergency in this case? So for me, I agree with NHI and all of that, but we need to be intentional about building people's trust in the quality of care that they will get. Why are people doing medical tourism? It's because they are sure of the confidence, or they have confidence in the healthcare they will get.
Yeah.
Yes, recently I listened to the presentation of the leadership of MPSCDA, and it's quite interesting that they did some survey to get people's confidence in public facility. It's increasing. So meaning this is the right time for us to then consolidate on that.
Yeah, I agree.
Because the hope is high, everybody's excited about the new structure we're having. So how can we just quickly leverage those quick wins, bring more facility on board, and we are not saying 1 PHC per ward or 1 EDIS per ward, but I then target population to map what
that,
number of facilities that you're able to give birth. So that it's like when it is a woman, I want a Nigeria where a woman dying will mean you have to summon the leadership of that community, everybody to come and speak. I want that word. Success for me is in 10 years' time or 20 years' time, I'm sitting with my children and I'm talking about maternal mortality. It's something they can only understand because they read it in the textbook. To me, that's what success looks like. Where I say that, there's a time where 1 out of so number of women died. I'm like, really? And for me, that's success. But for me, I say something jokingly almost all the time that I actually think at some point they need to take all of us for rehabilitation. Because 15 years ago, if you hear anything like someone is kidnapped or somebody died, there is a way we feel.
Yeah.
But have you seen how it looks so normal that they will say, that woman died while giving birth? I'll be like, and you continue what you are doing. We are too resilient. And as long as we continue to take it as a norm, it will continue. Yeah. So for me, I'm looking at a world where every woman life adds some value, and every stakeholder from the highest point to the lowest level gets some shake off where a woman died, because you must provide explanation and account for what killed that woman. Yeah. So until we get to that point, I do not think we can actually make the kind of genuine progress we look to make.
Yeah, I think like you said, success for me is, at least before we get to that point, is everybody's seeing it as their responsibility as
Yeah.
well, and working towards working together. Is not thinking, oh, this is just my part, I'm going to work on my part, I'm going to just focus on this. For me, is they're already seeing it as, I have a part to play, and this is the piece of the puzzle that fits into this
100%.
person's piece, and it ensures that the entire puzzle is together and we are working together to solve the problem.
Yep.
And eventually the success that you had talked about is very clear and it shows.
Yeah.
Yeah, thank you very much. I think my guests have taken over the conversation.
I mean, I told you that before I take over hosting
and
from you.
have asked themselves questions and have answered questions, and luckily they were in line with the things I planned
Fantastic.
to ask. And so yeah, but before we ask the last questions, I want to summarize this. I want to say, please like, subscribe, share, comment, give us a thumbs up. Whatever it is that you do, please do it. I'm just going to consolidate on what you both have said, right? One thing that stood out to me was integration. We have a lot of things going on. Nimi, you mentioned that. Afiz, you also mentioned that. There's a lot going on. There's a lot that the government is trying to do, and this donor, this organization, that organization is trying to do, but we don't have an integrated system, right? And so it's like a broom, using one stick of broom. Each person is using one stick of broom there, and then you just keep. You're not doing anything, but if you bring all the brooms together, and I think that's what the swap
exactly
is about.
Towards that,
So hopefully we get to see that changing. The second thing I got from you, Afiz, which I think is very important, and like when you said this, I was like, why did we not do these things? Is that public-private partnership? We've been talking about public-private partnership, but we've not operationalized it, right?
Far from it.
And whenever we are planning, even me individually, whenever we are planning about crashing the maternal mortality problem, we typically think of public hospitals. And you've just said now that why are we not also counting private hospitals?
Yes.
But when it comes to maternal mortality, we don't look at them as private hospitals. We look at them as part of the system that we have to solve this emergency.
Yes.
All hands on deck.
Yep.
Right. So now these are some things you've operationalized. I want us to, the final point,
Yeah.
from a policy angle, right? I'm giving each of you 1 minute each.
Yeah.
From a policy angle, how do we, these solutions we've brought up from the community level to the facility level to, we've even talked about the policy level at some point, but I want to hear strictly on the policy level, what policies do we need to set in place, or if there are any that you already know that are in place, to consolidate everything we've talked about, and so that in the next 10, 15 years, Afiz's dream, my dream, and I'm sure your dream
Of course,
also comes true.
Yeah. I think for me, maybe I'll go first. One is where I started from. We need to declare maternal deaths as an emergency. There needs to be a policy that strengthens the MPDSR, who do the maternal and perinatal
Surveillance,
labor autopsy. We need to do that, such that if the head of an household knows that if somebody dies in my house, I will have a lot of questions to answer.
It's everybody's problem.
It's everybody's problem. Meaning, if you have your neighbor that the wife has been pregnant and you are seeing signs of negligence, because you know that you will all be investigated, it will be a big issue to say, let me go and report you. More like a whistleblower policy. We need that. Let me use myself as an example. If my driver's wife is pregnant, I'm the first to ask him. I ask almost every day, how is madam? Has she registered in an hospital? I ask her today, what's the name of the hospital she registered? I would like to visit the hospital. Because I know it will be a slap on me if anything should go wrong at delivery points. Knowing she work with someone who has a lot of passion, interest in seeing women thrive.
Yeah.
Right? I don't now want it to be like for my own personal pride or conviction. I want it to be a policy that hold people accountable and challenge everyone to see a need to address maternal and newborn health as the kind of emergency that it should be. For now, it just looks like a walk in the park and it's not being addressed as an emergency. That's the biggest policy I'll be pushing for.
Thank you, Afiz. I like that. Everybody will collect.
Yes, that's the word. Everybody will
Everybody
collect.
Everybody go collect.
If your colleague is pregnant, you're asking every day. I hope you
How
are taking
far?
your
Have
MMS.
you done your ANC
I hope you've done
class?
your ANC. When was the last time you did your ultrasound? Is your baby cephalic or transverse? You're already asking all of those questions. And you are saying
There's
this.
no way they will not just quickly get on it.
Yeah, because if yes knows that if any of our staff die from giving birth, all of us, our life will be on pause. You will be the one checking on your colleague that is pregnant. That I hope you are on your MMS. I hope you registered. But for now, that's why I say our brain probably need to be formal. We all need rehab. It just look normal.
Yeah.
Mm-hmm.
You will see messages, somebody will chat you on the go. I just lost my wife.
Yes.
And the best, trust me, the food you are eating, you continue it. That's the level of.
Oh my God.
I'm so sorry.
I'm so sorry. Please, my regards to madam. I'll make sure I visit you tomorrow evening. It's that bad now. But if I know, if everyone see it as just like your word, everyone will collect. Until everyone starts collecting, that policy that make everyone collect, I'm not sure we address and achieve the kind of results we want to see as the country over.
Yeah, I completely agree with you. And I want to say that I share the same sentiment. But I'll add to it, which is the policy around integration, what SWAP is trying to do. And I know that they've operationalized a lot of things, but just kick it even into policy that no matter what, no matter which government passes, it stays.
Yeah,
Because there's another thing
so national
at
level,
domestic. Exactly.
100%.
Because that's what we typically see. This government would leave and then another thing, new thing comes up.
Absolutely.
Let's shape, just exactly socialize it. Let's make it the norm and because there's reason to it, right? And it makes sense to do, and just let's have that at all levels so that it's set in stone. I think that's
I
it
agree
for me.
completely. Brilliant. I agree.
Yeah, thank you guys so much. I'm a little bit sober because this is a conversation, as I said, is very dear to me. Before I joined ACE, I did like I came with the passion, and then I came to ACE, and it's a passion that is institutionalized, would I say. Like ACE is very passionate about crashing the maternal mortality rate and solving this crisis, and we are doing a lot of work towards that, but we alone cannot do a lot. We can only move our little needle, and we need a lot of things, a lot of systems in place to be able to move that needle to where it is supposed to be able to achieve our goal of having no woman dying, no child losing their mother because they were trying to bring a brother or a sister into the world, you know. But we've spoken a lot of things, and I just hope that I know that we here are trying to practicalize these things, but I hope that a lot of these things get operationalized. Some are being operationalized. A lot of them get to be operationalized even further and integrated into our system.
Can I say one more thing, please? Sorry about
please,
that.
Please,
but I
you're
used
my
to speak
guest.
to people. No, it's just because the key thing that Afiz mentioned and you've also touched on is allowing me to reflect. Do you actually think about your neighbor that is pregnant? Do you actually ask the right questions? Not checking and monitoring when they are due or seeing if they are like it's actually having you understand what I'm saying? So
question that makes sense.
Yeah, I implore you to actually sit and reflect on what has been said and know that it's also your responsibility. It's not just the government's responsibility. They will do what they need to do. They will be held accountable for what they need to be done. They need to do rather. But you also should be held accountable for what you can do at your own on your own end. You understand what I'm saying? So I urge you to take that responsibility as well and ensure that women around you have access to care. They're able to know that, oh, I can access care here. I can do this here. Right? And you are providing the right information and knowledge for them. So that's what I wanted to just do. Sorry about that. So I just wanted to make sure that
don't apologize.
The message
love
is
that.
passed. Yeah.
Yes, I love that. Thank you so much, guys, for joining us. Thank you so much, Afiz. Thank you, Nimi, for joining us. And you, the audience, you are our MVP of the year. Thank you so much for joining us. I hope you enjoyed the session. I hope you would you would comment, tell us what you think, let us know your thoughts. Do you have a solution? Do you have a game-changing solution? Even if you want to email us, to say, how can we operationalize this beautiful solution I have? We'll be very glad to listen to you, to take you as well and run with it. Thank you so much. And now we're going to say bye for now until the next episode. Don't forget to turn on the notification button so you can know whenever we come back on your screens. Bye.
Yeah. Bye, everyone.
Bye.
Thank you.
Thank you.